The moderator for this section was Jay Pashrika, who's a wonderful man, but he's not here. So I'd be happy to stay, or is somebody else going to do this? All right. Oh, sure.
We're running overtime, which is cool. Okay.
Prakash is here. Yeah. Oh, is Prakash not back?
He's on his way.
Okay.
Yeah. If Uber picked him up and stuff, he's on his way. So anyway, we're running a little late. We'll switch the order of things, but dinner is supposed to be in like 15 minutes. Don't worry about it. We're going to give you at least a 45-minute break after we're done here before we convene for dinner. Dinner will be upstairs where you had lunch. So just relax. It looks like everyone's having a fantastic time here. Let's enjoy and not just worry about the time too much. Having said that, they each have 15 minutes precisely for that.
Each have 15 minutes. Absolutely. And I want to correct a systematic error that has been committed here from my colleague Ikuo Hirano, who will be talking about the place for medical therapies, drug, botox, pneumatic dilation for EMDs in 2019. Ikuo.
So this will be the slide deck, Hirano. Great. Okay, so we're going to change the order up a little bit here. I'll try to do this in 14 minutes and give you guys a minute back of your time. I'm going to look at medical therapies for esophageal motor disorders in 2019. I'll be covering achalasia, jackhammer, nutcracker, distal esophageal spasm, and I just wanted to introduce a topic of opioid-induced dysmotility, which we're all seeing in greater frequency now. And I put this picture up to just make the point that a lot of the literature I looked at was very old, going back about 30 to 40 years. So starting off with achalasia, calcium channel blockers have been looked at in 2 placebo-controlled trials and 1 crossover trial comparing 2 different calcium channel blockers. The studies using nifedipine, given sublingually, did show efficacy in terms of symptom relief of dysphagia, as well as significant reduction in lower esophageal sphincter pressure by about 30 to 40%. The one trial done by Dr. George T. did not show benefit for calcium channel blockers, comparing 2 different calcium channel blockers, but the caveat to that study was that they used the calcium channel blockers orally. And one thing we know about achalasia, these patients can hold on to food and pills for many hours, if not even days. This is a patient that came to our GI lab on a 2-day liquid diet, still had solid food, and once the solid food was removed, found lots of pills, residual pills in his esophagus. So clearly, oral delivery of medications for achalasia is not going to be very effective, particularly in type 1 and type 2. What about comparing nifedipine or calcium channel blockers to pneumatic dilation? There's actually been a randomized controlled trial that compared these 2 strategies, done quite a number of years ago from a group from Italy. Randomized trial, nifedipine, again, given sublingually compared to pneumatic dilation using a dilator that we're no longer using in clinical practice. But they followed a fairly aggressive dilation protocol, starting with 35 millimeters and going to 40 millimeters. So I think we'd all agree that's a fairly aggressive dilation protocol. Basically comparable results for medical therapy or pneumatic dilation, achieving symptom relief in 75% and also manometric improvement in terms of LES pressure. So comparable benefits for these 2 therapeutic strategies. Other medical therapeutic regimens have been used, particularly nitrates, nitric oxide donors, and here the data even looks actually a little bit better than the calcium channel blocker data. Again, given sublingually, isosorbide dinitrate at very small doses, 5 milligrams, given 3 times a day before meals. Again, symptom benefit as well as manometric benefit. Reductions in lower esophageal sphincter pressure here are actually better than you saw with the calcium channel blockers. In fact, one of these studies actually crossed over patients to get either nifedipine or isosorbide dinitrate and showed more significant reductions in LES pressure with the nitrates compared to the calcium channel blockers. The problem with the nitrates, of course, is the headaches that most patients do complain about. The newest medical therapy on the block is sildenafil, which is the phosphodiesterase type 5 inhibitor, which increases cyclic GMP levels, cyclic GMP being the major second messenger for nitric oxide. This has been studied in achalasia, 14 patients in a proof of concept study. This study was interesting. They put the manometric catheter down and then infused the sildenafil through the gastrostomy port through the manometric catheter. So they're delivering it transgastrically to the patients instead of trying to give it transorally. They demonstrated significant reduction in lower esophageal sphincter pressure, and the effects lasted for about an hour. So it's really a proof of concept study. So I think the summary for achalasia is that the smooth muscle relaxants are effective at reducing lower esophageal sphincter pressure, but the long-term use of this type of strategy is not very practical to have patients take a pill every time they want to eat, and also limited by side effects. Now, I couldn't resist, we're in Vegas, I couldn't resist using this cover magazine from Us Magazine to talk about Botox. Now, Botox has a very low impact factor, but I'll just make the note, if you read the subtitle here, they use doctors or physicians to judge which stars got Botox and which stars did not get Botox. So maybe they're trying to improve their impact factor and use evidence-based medicine. So Botox, the data was extremely exciting. I remember when I was a fellow, this really took the motility world by storm. This is the randomized controlled trials comparing pneumatic dilation with botulinum toxin with 1-month outcomes. And the data was extremely exciting. This is the first time a really effective medical therapy could be targeted at the lower esophageal sphincter pressure for achalasia. Controlled trials comparing these two strategies looked quite comparable. You can achieve relief of dysphagia in a comparable number of patients using either Botox or pneumatic dilation. The problem, which you all know, of course, is the long-term data. When you look out to a year, Botox starts to fail, but pneumatic dilation remains durable. So the conclusion here is that given the long-term or limited long-term effectiveness of Botox, Botox is really restricted to what we call the elderly and frail patients. I would then argue that in 2019, this term frail and elderly becomes quite difficult to define. We have POEM patients who are 93, 94 years old undergoing POEM procedures for achalasia. So I'm not sure what really defines elderly nowadays. The other question that's come up about Botox is how safe is it really? I just point your attention to 2 recent reports of death related to Botox injections for spastic disorders. One was a patient with esophageal spasm. The other was a patient with achalasia. The achalasia patient was quite old, 89. The other patient was actually not that old, 64 or so years of age, given Botox injection to the esophageal body. Both developed mediastinal infections, abscess formation, and death. The other adverse effect, which the surgeons, of course, very well aware of, are the adverse effects on surgical myotomy that's been reported, difficulty with the identification of the submucosal tissue plane that can affect a hairline myotomy, but also POEM procedures, increased risks of intraoperative perforation and prolonged hospital stays. However, the data has not shown any effects on the long-term efficacy of the surgery affected by the prior Botox injections. The other disorders I want to briefly mention are the other spastic non-achalasic disorders, jackhammer, nutcracker, and distal esophageal spasm. Now, I had to go back in the literature almost 40 years to Joel Richter's study using nifedipine for nutcracker esophagus, which showed efficacy. Nifedipine is very effective in not just reducing the lower esophageal sphincter pressure, but also the amplitudes and duration of esophageal body contractions. The problem that was nicely highlighted in this randomized controlled trial of placebo versus nifedipine is that when you looked at symptoms, the symptoms didn't change. You could improve the manometry, but you couldn't change the symptoms, particularly of chest pain. In terms of chest pain frequency, chest pain severity, they did not change between placebo or active drug with nifedipine. So this made the important point that for nutcracker esophagus, the treatment studies highlighted this dissociation between what we're seeing manometrically and what patients are experiencing symptomatically. In terms of therapies directed at distal esophageal spasm, here the data is not as convincing. Most of these studies have used nifedipine rather than nitrates, but have had trouble demonstrating any symptom benefit for the use of calcium channel blockers for the treatment of distal esophageal spasm. All small, uncontrolled studies. Looking at the newest kid on the block, again, sildenafil, the phosphodiesterase type 5 inhibitor. This was a second proof of concept study that first looked at patients who were control subjects and then looked at patients with spastic disorders. When they applied sildenafil given orally to healthy volunteers, they were able to demonstrate a significant reduction in lower esophageal sphincter pressure as well as esophageal body contractile amplitudes, as you would predict. When they then applied the sildenafil to a group of 11 patients with hypercontractility, The unfortunate thing with many of these studies is they start to group all hypercontractile disorders into one broad category. So they included nutcracker, distal esophageal spasm, a couple of achalasia patients, and a few patients with hypertensive lower esophageal sphincter pressure, which is not in the Chicago classification version 2.0. So they demonstrated that the sildenafil could result in manometric improvement in the majority of patients. However, symptom improvement was achieved in less than half the patients, and only 2 of the 11 patients who were treated with sildenafil continued therapy because of side effects. So smooth muscle relaxants have at best modest motility benefits for these hypercontractile non-achalasic disorders, and the clinical utility has been limited by both poor symptom benefit and side effects. I just wanted to highlight the efficacy. There is efficacy for the medical therapy of these disorders. This is a patient that we saw recently who had a jackhammer esophageal pattern, DCIs 10,000, also EGJ outflow obstruction. This patient was deemed not to be a candidate for more invasive therapies because of their nutritional status. We then actually, just as a proof of concept, treated this patient with nitroglycerin short-term. So here's the timescale has been collapsed, but these DCIs are all in the several thousand range, up to 10,000. Given sublingual nitroglycerin, and there's basically abolition of the esophageal body contractions for a period of several minutes, and then you see return or resumption of the hypercontractile state after the nitroglycerin wore off. What we did with this patient, the patient actually got a gastrostomy tube for nutritional status, and we kept the patient on isosorbide dinitrate to prevent aspiration of oral secretions that were being swallowed. In terms of botox injections for distal esophageal spasm, here the data looks better than the data for the calcium channel blockers. Symptom benefit has been demonstrated. Most of these studies are injecting the botox into the esophageal body. Some of the studies have injected the botox into the lower esophageal sphincter. I just want to look at 2 recent controlled studies that have been placebo-controlled studies looking at botox compared to placebo for non-achalasia motor disorders of the esophagus. The first study was done by Jan Tock's group, double-blind, randomized, placebo-controlled crossover study, 22 patients with dysphagia as a primary symptom. But again, they looked at a potpourri of hypercontractile disorders, including nutcracker, jackhammer, or distal esophageal spasm. Botox was delivered here at the EGJ as well as 5 centimeters above the EGJ, and then patients were crossed over to get either placebo or Botox at 1 month. An example of a patient they thought had a treatment success, jackhammer pattern before therapy and after Botox injection, improvement in the hypercontractile state. When they looked at the overall treatment group, again, this potpourri of different hypercontractile disorders, they were able to demonstrate symptom benefit for overall symptoms that included chest pain as well as dysphagia, as well as symptoms of dysphagia. This was true for the patients who got Botox up front or compared to the patients who got placebo up front. For some reason, when they looked at the patients who got placebo up front and then got Botox, they had a harder time demonstrating significant improvement in symptoms. So the Botox seemed to have better efficacy for the patients who got it up front compared to placebo up front, probably because the patients were getting a placebo symptom response that diminished the Botox response later on. When they looked at physiologic outcomes from the Botox injection for these non-achalasic esophageal disorders, the Botox did significantly reduce the lower esophageal sphincter pressure and also significantly reduced the esophageal body contractile amplitudes, and only in the subset who got placebo first and then got Botox. A trend for improvement was seen in the patients who got Botox up front. So this inconsistent symptom and manometric benefits of Botox for hypercontractile disorders may reflect this very small sample size of the studies and the inclusion of heterogeneous spastic disorders. The second trial I want to mention is a study that was presented at DDW last year, but has not yet been published, just in abstract form at DDW. Again, a very similar study design, randomizing patients to get either Botox or no injection, 23 patients, but unfortunately, again, a potpourri of hypercontractile states, 4 spasm, 12 jackhammer, and 7 achalasia type 3 patients randomized to Botox or no injection. If patients remain symptomatic, they could then go on to get a Botox injection at 3-month follow-up. The data here first looked good. They were able to show significant improvement in an Eckert score after injection or no injection. The problem was that there was no difference between the patients who got Botox compared to the patients who got no injection therapies. That is, both groups showed symptom improvement at the 3-month follow-up. Here's an example of one of the patients that went into this trial, jackhammer esophagus, 60% of swallows having a DCI greater than 8,000 at baseline. At 3-month follow-up, things look better. 90% of the swallows now had a DCI of under 4,000. Unfortunately, this patient did not get Botox, but got no injection. So looking at the other, just at the subset of the 12 patients who had only jackhammer esophagus, again, here, symptoms seem to improve, but they improved equally between the patients who got no injection compared to the patients who got Botox injections. Looking at objective parameters on manometry, DCI decreased, but decreased equally between the Botox injection and no injection. So I think this small study, again, not yet published, but presented, highlights the importance of placebo-controlled trials in these hypercontractile disorders, given the poor symptom correlation and uncertain, undefined natural history for these hypercontractile disorders. The final point I want to make is opioid-induced esophageal dysmotility, which we're starting to see more and more of now that it's being recognized. The major disorders that have been reported with opioid use include hypercontractile states as well as EGJ outflow obstruction. There have been 2 prospective acute studies that show that if you inject patients with morphine, they have impaired LES deglutative relaxation. And now we have retrospective data from the Mayo Clinic showing that chronic opioid users demonstrate incomplete lower esophageal sphincter relaxation, which can be read out manometrically as EGJ outflow obstruction, as well as reduced distal latency that can mimic distal esophageal spasm. The cessation of opioids for greater than 24 hours seems to be associated with improved manometric readings. An expert opinion, namely Dr. Krillis, has suggested that Botox injection be considered as a first-line treatment option for symptomatic patients who are unable to stop their opioids. So to conclude, medical therapies for EMDs in 2019 for achalasia, although oral and sublingual administration of muscle relaxants are manometrically quite effective, the clinical use of this approach has been limited by the need for daily administration before every meal, problems with oral delivery of these agents, and mostly side effects. Botox is, of course, highly effective and comparable to pneumatic dilation in the short term, but limited by its long-term durability and the efficacy of alternative therapies, which we'll hear about from Dr. Swanstrom. And for the non-achalasic hypertensive esophageal motor disorders, the effectiveness of medical therapies and Botox for manometric features does not consistently translate to symptom benefit. Treatment needs to instead consider the variable phenotypes, poor symptom manometric correlation, and uncertain natural history of these disorders. And I think it's important to consider achalasia variants and opioid-associated dysmotility. And finally, I think the studies to date have shown the importance of multi-center randomized placebo-controlled trials in these hypercontractile disorders. Thank you very much for your attention.